bringing together voices in child and youth healthcare. This is CAFC Presents.
CAFC would like to thank the following member organizations for their generous support of our knowledge translation activities: the IWK Health Centre, the Children's Health Foundation of London, McMaster Children's Hospital Foundation, the Children's Hospital of Eastern Ontario Research Institute, the Children's Hospital Foundation of Manitoba, the Montreal Children's Hospital Foundation, the Holland Bloorview Children's Rehabilitation Hospital Foundation, the Children's Hospital Foundation of Saskatchewan, and Trillium Health Partners. We would also like to thank the following Keystone and program partners for their ongoing contributions that support all of CAFC's programs and activities. If you have any questions or comments for our panelists, please type them into the question box at any time during the presentation. You can also share your thoughts and questions on Twitter by tagging @CAFCTweets and using the hashtag CAFCPresents. All of our webinars are recorded and can be found on the CAFC Knowledge Exchange Network. Use the CAN to share these recordings with your colleagues or register an account and post comments, links, or other resources that you think will be of interest. And be sure to sign up for the CAFC Presents weekly email newsletter to stay up to date with upcoming webinars and our recorded webinar archive.
Hello, everyone, and welcome to today's episode of CAFC Presents. I'm Doug Maynard, the Associate Director at CAFC, the Canadian Association of Pediatric Health Centres. And today we're going to be talking about the TREKK PedsPac, having what you need at the bedside to manage acutely ill children in the emergency department. And it's a great pleasure to welcome back our colleagues from TREKK, which is part of the Government of Canada's NCE program, their National Centres of Excellence program, and TREKK stands for Translating Emergency Knowledge for Kids. I'm sure many of you have heard of TREKK. We introduced them on a series of webinars a couple of years back when they were sort of first launching and introducing some of their initial sort of knowledge translation products and some of their plans. And so it's great to have them come back and talk about some of the great work that they've been doing over the past few years, as we haven't heard from them in a couple of years on this on our webinar series. So the TREKK website, trekk.ca, is a great resource with lots of great information, various types of various levels of research information that you can find, or not emergency department information that you can find on there. It's laid out really well, so I encourage everyone to check out that website at some point. So it's my pleasure to welcome today's presenter, Dr. Manoj Abour, who is an associate professor in pediatrics in the Division of Emergency Medicine and Vice Chair and Chief of Pediatrics at the Children's Hospital of Eastern Ontario in Ottawa and at the University of Ottawa. She's also currently leading 2 CIHR-funded implementation trials and is the co-director of the TREKK network as well. So it's my pleasure to hand the virtual podium over to Dr. Manoj Abour. Over to you.
Thank you, Doug. And thank you for that great and very welcoming introduction. I'm so pleased to be speaking with you all today about TREKK, and in particular about the TREKK PedsPacs. And I'm glad that Doug gave us a bit of that refresher about what TREKK is. I am going to be discussing a little bit in the course of the presentation as well. So, just a little bit of background in terms of why we started TREKK in the first place. We know that within specialized pediatric hospitals, we do a lot of training, preparation, and research to really optimize the emergency care we deliver to children. However, about 85% of Canadian children who seek emergency care go to a general emergency department that's not part of a children's hospital. That's just reality. That's our geography in this country, and children should be able to seek care closer to home, so they're naturally going to go to the hospital that's closest to them, which probably isn't going to be a pediatric center. We know that there are difficulties in getting the right resources and training. We know that difficulties in getting the right resources and training have been cited as barriers to providing the best possible care in these settings. And this has resulted in variable levels of emergency care for children within Canada. For example, we know that 40% of children do not get treatments for which clear evidence is already existing, and 1 in 5 get treatment which is of no benefit or possibly even harmful. So the reasons why this variation and discrepancy exists are very understandable. If you think about, anybody who has known or been in in any emergency department, there's a lot of complexity there in the types of patients, the age ranges, the types of medical and surgical problems, the general chaos that's there. It's physically and cognitively a very demanding type of place to work in, and yet we all love to be there. Keeping up to date with any literature is a challenge, but in particular, if your main business is adult medicine and there's all the complexity involved with that, it's even more challenging to keep up with the pediatric emergency literature. And then finally, even if a particular ED health professional is able to keep up with the literature, we all work in a system. We work in a team with other members. We work in a system where resources and equipment are either there or not, and how they're set up will really dictate how well we can actually deliver on those types of care. So before I discuss the PedsPac, I'd just like to give a bit of a brief overview of the TREKK network and some of the work that we've completed thus far. So our vision at TREKK is to deliver the highest standard of care to every child, whether they choose to seek treatment in a pediatric or a general emergency department. And our plan for this is really about building capacity in 3 various stages. The first was a needs assessment to understand what are the needs. And I should add that TREKK is really targeting 2 main groups, one being emergency health professionals, and the other are parents and health consumers. So we did a needs assessment of all of those individuals. Our second phase of the plan is to assemble evidence relating to those areas of need, what we call a knowledge synthesis, and then third, to develop and share knowledge in the forms of practical tools. And this is our TREKK team. Our director is Terry Clausen at University of Manitoba. He's been a great visionary and leader in this whole network development and sustaining our activities. My co-directors are Shannon Scott and Lisa Hartling at the University of Alberta, responsible for needs assessment and knowledge synthesis. And David Johnson and myself have been responsible for implementation related to the network. And of course, we could not do this alone. We have quite a number of pediatric site partners. There's the group here, the 14 that are listed here. McMaster Children's Hospital and Montreal Children's Hospital are new arrivals to the team, and we're very glad to have them on board. And this is just an overview of our whole TREKK network. You can see we're mostly clustered around the border, but there are some northern sites as well. So our model is that each pediatric hospital partners with a number of community hospitals, and we've called those community hospitals TREKK sites. And the idea is that the community hospitals relate best to the referral center that they work with, the pediatric referral center. And so that's how our partnership model has evolved. Since the start of this, and even since this graphic, there are many more community hospitals that are part of our network, and many more that want to be part of the network, and we would welcome that as well. So you can see that many of the sites of Vancouver, BC Children's Hospital here on the left has a number of community hospitals that work with BC Children's, and the same goes across the country. And you can see way up here north in Yellowknife, probably one of our most active and passionate TREKK sites is the Stanton Hospital in Yellowknife, and they've been a great partner. I alluded to our needs assessment, and this has really driven a lot of the work that we've been doing. We went with iPads to every one of the TREKK hospital sites, the community sites. We went with iPads, and we basically surveyed health professionals that were on duty at the time. We surveyed families and parents, health consumers, caregivers. And then we surveyed, we got information from other groups as well to kind of round out that information. And we identified a number of priority conditions based on, what the surveys told us. And they're listed here in this table. There were 14 priority conditions, some of which were identified from the surveys directly. Some came from unperceived needs, for example, from coroner's reports, or CMPA, Canadian Medical Protective Association information, really trying to tell us where some of the problem areas might exist. And then we rounded that information out with a series of focus groups that came later. And Doug alluded to our TREKK website. This is a copy of the front page, and really just to highlight that the website really is there to serve a number of different stakeholders, our primary ones being clinicians at the TREKK sites and beyond, as well as patients and families. And really I'm going to focus more of the discussion on the resources that are for health providers here. So working from the needs assessment, we've synthesized the best available knowledge and distilled these into manageable information for use in the ED setting. So in other words, we tried to take all the research evidence that's out there and interpret it and come up with a series of bottom line recommendations for specific pediatric conditions. Here's an example of one for DKA. This is the front page and this is the second page, and none of the bottom line recommendations are more than 2 pages. We summarized the key information related to assessment for that condition and then management for that condition. We've also highlighted some specific areas of things not to do, things to be cautious for, etc., criteria for safely sending them home, criteria for admission or transfer to a referral center. And of course, for anyone who wants all of the background research information, the overviews of research, all of that information is available on our website. And just to show that we have a number of bottom line recommendations for different conditions. This is one for multi-system trauma. This is one for concussion, and all of the documents are translated in French, and importantly, they're reviewed by French health providers to make sure that the French is actually meaningful and appropriate as would be used in an emergency setting. Back to our TREKK website, we've compiled all of our resources into an evidence repository, and you can search by condition, or you can search by type of resource. And if you click on one of the buttons here, it'll open up into all of the different resources that are available for that condition, and you can either download or it'll be a link to that site. We have a number of other resources. So we've partnered with Anton Hellman of Emergency Medicine Cases, who has a really popular podcast series. They've had over 3 million downloads since 2010. And we provide the pediatric emergency medicine expertise and helping him creating the podcasts related to pediatric conditions. As I mentioned, we have a number of pediatric parent tools. This is one that was prepared for Croup. And then, of course, we have the PedsPacs, which is what I'm going to be talking about today. We are in development in creating a TREKK app that will be available for iOS and Android, and it will be available for user testing in the coming months. So everything that's available on the website will be available on the app, and it will be accessible and user-friendly. And more importantly, we're setting it up so that if the Wi-Fi is not great, which can be the case in many hospitals, that you don't need Wi-Fi to be able to access it. It needs to from time to time you need to update the information through an internet connection, but to use it on a day-to-day basis, it's not required. I think that'll be really helpful to people working in emergency departments. So back to talking about PedsPacs. So the objectives are there listed, and they were as advertised. We know from our needs assessment and from our day-to-day interactions with colleagues in community emergency departments that a critically ill or injured child is highly anxiety-provoking for emergency physicians and nurses, and not to mention the families as well. We know that health professionals try to address this need to keep up to date through professional development and other types of updates, but in that moment when they encounter the acutely ill child, it's really hard to remember what to do, or it can be hard to remember what to do. And of course, the margin for error is not that forgiving. And finally, even if they do remember, the emergency department system that they work within may not be able to support that care. Time is critical. The sooner the recognition and intervention, often the better the outcome for the child. So this is what led us to create the concept and the deliverable of PedsPacs. And PedsPacs are really packaged tools. The pack is in the packaged tools to guide effective evidence-based management of acutely ill or injured children. We know that in most cases, health professionals know what they should be doing, but they may not remember it. They may not be working synchronously as a team to deliver that care as optimally as possible. So by putting these tools together that are really geared for the team, that are better if there's previous training around the PedsPacs, but even if there wasn't, or even if there was a year lapse since that training, that you can actually just use these as is, and it will guide you effectively through the care. So face-to-face outreach education was a big part of our deliverable with our TREKK site community hospitals, and it continues to be. However, and it pains me to say this as an educator, education is not enough. We know this. There are many challenges related to delivering effective simulation outreach. So as part of our face-to-face outreach where we go and discuss particular pediatric topics, we do high-fidelity simulation scenarios to help really live the experience of managing an acutely ill child. This can be a really great experience, and we're continuing to provide this experience, but at the same time, it's quite resource intensive in terms of shipping the equipment to the site, the setup costs associated with that. We know that although the people that are there really enjoy it, there's often minimal reach beyond those who actually make it to the presentation or to the simulation session. And some health professionals are reluctant to actually participate because they don't want to show what they don't know, and that's a very natural kind of reaction. Even if they did participate in the sim session, it could be a year, it could be 2 years till they see a child with that condition where they're the ones responsible to manage. So it can be difficult to retain the knowledge and the skills related to that. And we also know, as I've alluded to already, that we really need system change to support the standardized practice. So if a particular type of management treatment is required for a condition, the ED physician needs to be able to ask for it, and it should be available. If the eMERGE department isn't set up to support that, then we're not able to deliver that to that particular child. So it's really important that this background change happen to support this. So the TREKK PedsPac includes a number of different types of what we call just-in-time clinical tools or point-of-care tools. And by that I mean tools that you can actually use when the patient is right there in front of you. You don't have to read up on it and prepare before using it. And the PedsPacs will include a number of different types of tools depending on the condition that's involved. So there may be a poster that's available at triage to help recognize that condition, and I'll show an example of that. There will be, every PedsPac will have an algorithm that's focused on assessment related to that condition and the time-based management steps that are required. There are pocket cards that will highlight specific red flags, things to keep in mind, again related to assessment and management of that condition. There is a pre-printed drug dosing binder, which is an incredible resource that is all based on age and estimated weight, and all the drugs and equipment are pre-calculated for that particular estimated weight. There are pre-printed order sets, so for a particular condition, all the specific assessment, investigations, and treatments that are required are written out on a pre-printed sheet, again as a memory aid or a cognitive aid to help remind the team of what is required. And then finally, for many of these conditions, these are severe critically ill patients, they often will need to be transported to a referral center, and there's a checklist to help identify the key things that must be put together so that when you're ready to transport that patient on, there are no delays in getting everything in order. And then finally, we also have a set of videos to help prepare to do some teaching around these cognitive aids, and these are based on simulations around that particular topic area, where aspects of assessment and management are highlighted throughout the video. And again, these are used more for education purposes. So I'm just going to go through and show you some examples of what all those tools are. This is a copy of our triage sepsis screener. So these examples I'm showing you all are all related to pediatric sepsis, and in particular severe sepsis. This is a tool that we created in collaboration with CAFC. CAFC was working already on a triage screener, and when we heard that they were working on this and they were about to look at implementation, we joined forces and put this together with our PedsPac. A big part of the problem with pediatric sepsis is recognizing that's what you're dealing with. And so this is a tool to help aid the triage nurse to identify a child that's at risk for severe sepsis and be able to get the treatment started as soon as possible. This is the management algorithm, and this is a poster that's available that's scalable to any size that's required, depending on what your needs are in your emergency department. So in many emerges, these are created as 2 by 3 foot posters that are mounted on a wall. It can be available. It can be printed on a clipboard. It can be created as a poster as an intermediate size. Really, whatever works in the emergency department. I've been to many different emergency departments across the country, and if you've seen one emergency department, you've seen one emergency department. We're all very, very different, and wall space is limited in every single emergency department. What we're asking people to do is to ideally create or dedicate a space within their resuscitation room or trauma room for pediatric resources, and in particular the PedsPacs, so that there's one go-to place. And you have a sick child come in, you look in that place, and everything will be there. And that's one of the things that we're working with the various emergency departments to help get that set up. So this sepsis algorithm identifies they're all set up in a similar way. The top blue boxes are really about initial recognition, confirming that's the condition that you're dealing with, and then what the initial management will be. And then we go through in a time-based way what specific activities should be happening, reassessment points and what to be reassessing, and then caution box to be what to be watchful for that particular condition. We also have in several places reminders to alert the pediatric referral center that you're dealing with a child with this condition to help prepare for that eventual transfer should that need to happen. And then specific issues to discuss with the pediatric referral center. This is a copy of some of the pocket cards that we've created. So these are obviously bigger. They are suited to fit the size of a typical hospital ID badge. Many places will clip them right onto the ID badges and have them available for quick resource. We know across the country that in most general emergency departments, it's really difficult to remember what's normal for a pediatric heart rate, what's normal for a respiratory rate and blood pressure. And so we put these together into a pocket card. The green range is the normal range, which can be quite broad depending on what's going on with the child. The low and the high end are important in considering different types of critical conditions. So these are what's highlighted. And the normals that we have here are in line with the electronic CTAS guidelines that are going to be launched within Ontario and I believe elsewhere in the country as well. This pocket card, again, these two pocket cards will be flipped, so it's one card and the information is on either side. On one side, we have the definition of hypotension. Again, many people forget what is hypotension in a one-year-old. This will help you to remember that. And on the other side are specific red flags that we've identified over time that are important to consider in managing a child with pediatric sepsis. And for the different conditions, we'll have similar types of pocket cards with red flags identifying the important do's and don'ts related to assessment and management. And then we have our drug dosing binder. This is just the title page from the front of the binder. And it has a link to a website where all this information is also available online. It was created by our group at CHEO and is being used as part of the PedsPacs. And as I mentioned before, the drug dosing binder has all of the dosing information pre-calculated. So in pediatrics, everything we do is based on a per kilogram basis. Well, not everything, but many things are based on a per kilogram basis. And it can be difficult to remember all the particular things. So many sites use a Broslow tape, which will actually use the height of the child or length of the child as a proxy for the weight, an estimation of the weight. And many of the equipment and other types of tools that we need are actually indicated on the Broslow tape. Some of the drug dosing is available on the Broslow tape as well. But we also thought that this drug dosing binder was going to be a useful thing to have as a resource you can open as a binder, have it at the foot of the bed, and use this in your ongoing management. So in this example, we have a 4-year-old, so the estimated weight for that child is going to be 16 kilograms. The normal vital signs are listed here. The equipment and the specific sizes for the equipment are all detailed here. If they need to be cardioverted, defibrillated, the amount of joules given for delivery are here. And then we also included this part about hypoglycemia and how much dextrose to be giving because that's a frequent question that we get. And then for sepsis, we have the doses. It may be hard to see this on my screen for the medications that may be required for sepsis, including acyclovir, ampicillin, cefotaxime, etc. We have the concentration that it's delivered in, the dose, the volume that you'd be giving, any particular notes in terms of how to administer that. So all that information is there for every single weight category. So you open the page and that's all you need to look at. If you're dealing with statusepilepticus, you'll have different drugs. So it's the same thing. The different drugs are here. The actual dose that's to be delivered and the volume are all listed here, and then the administration notes. We also, depending on the situation for the child, they may need to be intubated and ventilated. So all the medications for rapid sequence intubation are listed again and pre-calculated based on that estimated weight. And then if inotropes are needed, so infusions of dopamine or epinephrine, again, that can be very difficult to calculate. How do you mix up that infusion bag for a specific dose that you're giving? The physician may say, I want to give 0.1 mics per kilo per minute, and the nurse says, how do I figure that out? In some cases, there are pre-filled bags or syringes, but the drug dosing binder will have all that information pre-calculated. So if you want to give 0.1 mic per kilo per minute of epinephrine, you know you're going to run 16 mils of the infusion, depending on which concentration of the epinephrine bag you have. And all of this is taught when we're actually implementing the PedsPacs. Here's an example of the preprinted order set. So again, this is for severe sepsis. And some community hospitals may not want a preprinted order set this complicated. They may just want to have the first page of the medications to start with, not some of the more specific types of medications. And that is something that can definitely be adaptable. But all of the investigations are listed. The fluid management and specific medications are listed here as well. And then finally, the transport checklist with the particulars that are required. We developed this in collaboration with some of our EMS providers who do the transport, just to help prepare sites to be sure that they have everything ready so that when the transferring team is there ready to transport the child, that there's no delays in collecting the various bits of information or the tools or equipment that are required so that they can safely transport the child. So that was a quick overview of all the tools that are available within the PedsPac. I think it's important just to talk a little bit about how we actually go about developing each of the PedsPacs. The PedsPacs are developed by a core group of professionals at CHEO. It's a multi-professional group including emergency nurses, trauma nurses, SIM educators, physicians, pediatric emerge physicians, intensive care physician, respiratory therapist, probably forgetting a few other people there as well. Oh, our pharmacist, of course, is integral to all of this. So we have a core group, and depending on the topic that we're working on, we will invite experts from across the country. We also have two other members, one from Montreal, one from Saint-Justine, and one from Montreal Children's, who actually sit on our core group. And then we have invited experts to help steer through the particular aspects of care for that condition that we're working on. It's really important that we be pragmatic about this so that we're not spending so much time in the development phase. Development takes quite a long time in the best of conditions. But to do this efficiently and expertly, we start with existing guidelines, best practice guidelines to actually create the algorithms. And so we spent a lot of time with developing the first one, the sepsis one. Now we've gotten better at it. We're moving along with it fairly quickly. Once we actually have a good draft of the algorithm and all the related tools that I've gone through, we actually go through quite a series of iterative review and feedback and revision, just to be sure that once we're ready to launch each of the PedsPacs, that it's actually going to make sense to the end users, that it's going to be a set of tools that they're going to look at, they're going to be able to understand, they're going to find helpful, they're not going to be confused by any particular detail that may not be necessary, and that it's going to be ready to really be implemented. We work with a graphic designer who helps set up all the look of all of the tools to make sure we have a consistent and professional look to them. And then we have a series of different committees and stakeholder groups organized throughout our TREKK network. That's what all of this is, the steering committee and our different advisory groups, just to review all of the tools and make sure, as I said, that they really are meaningful and appropriate. And this has been incredibly helpful. And of course, at a certain point, you want to stop asking for feedback, because when you ask for feedback, you continue to get feedback. But we reach a point where we have a bit of saturation and we're ready to move forward. The other part to all of this is that we're aiming to have tools that have distilled the very best and latest evidence. And so that introduces delays as well. We were very ready to launch our sepsis PedsPac, and then we got delayed because some of the evidence for aspects of the treatment had changed and really suggested that we should be changing our recommendation. And so that required some discussion, review, thought, and then reissuing a newly revised PedsPac. And this will be ongoing for us because we want to make sure that the tools that we are disseminating and having available are going to be the best available evidence. And so at a minimum, we are reviewing all of the tools at a 2-year minimum, or sooner if there's emerging evidence that really requires us to look at a change. The topics that we have for our PedsPacs are these listed here. The first 3 that are completed are severe sepsis, statusepilepticus, and diabetic ketoacidosis. We are beginning to work next week on our anaphylaxis PedsPac, and then over the rest of the year and into next year, we'll be working on the rest of the PedsPac topics that are listed there. And one in particular that wasn't originally on our list, but we've discovered would be a very helpful one to have is for the distressed neonate, where in particular the infant under 28 days of age, where the presentation in terms of how the baby looks may not be very specific, but it can be caused by a number of different types of conditions. For example, sepsis or cardiac or respiratory. They can all present with very similar features. So we thought a PedsPac for that condition in particular could be very helpful. I'd be interested in feedback from this group about other PedsPac topics. So all of what I've been talking about is related to development of the PedsPacs. Implementation is obviously a huge part to actually getting these into the emergency departments and getting them used. And as I've discussed, as part of our TREKK network, we have pediatric referral sites working with a set of community hospitals. And the pediatric sites are actually doing their own implementation for the PedsPacs, but they need to be available and are very keen to be ready to help coach community sites to actually implementing the PedsPacs. And so we created this brochure to help guide the different aspects of implementation. And I'm just going to zero in on the different types of activities that we're recommending. So depending on the capacity for outreach at the pediatric referral center and at the community hospital level, and the resources that are available to do this outreach, we recommend one of these 4 different types of sessions. So doing an outreach session with simulation, obviously working through these PedsPacs with a real case, and a high fidelity simulation case is really the best because it gives you that real feel of what it's like. You've got this 3-year-old child, you're concerned has severe sepsis, what do you do? And when you work through a simulation, it's designed to be as realistic as possible. And in my experience in doing this, sites almost feel like they're cheating by using the PedsPacs, but it's the whole intent is to actually work through the case using the PedsPac to help guide you. So the first option is outreach with sim sessions. If it's not possible to do a simulation session, you can still do the outreach and provide teaching around the various tools and details for that condition or topic. I've also done simulation. I've done simulation with a low fidelity, like a Resusci-Annie mannequin, and software for a high fidelity mannequin, and that worked quite well because it gave enough of that realistic feeling of working through a case while still illustrating how the PedsPac tools can be helpful in doing the assessment and management for that condition. And then, of course, we have the option of education at a PERK site. So PERK is the Pediatric Emergency Research Canada. When we talk about PERK sites, we're talking about the pediatric referral sites. There's the option of inviting professionals from the community sites to the pediatric site and doing train-the-trainer sessions with educators at the pediatric site using simulation as part of that. And then finally, there's the opportunity to do that at regional conferences. And many of I think all of our pediatric sites are very actively involved with regional conferences, and many have delivered teaching on the PedsPac tools and other TREKK tools at the regional conferences. And regardless of which of these activities the pediatric sites are doing, the important part is that there's ongoing implementation coaching to help support use of the tools and bring that information back to us centrally to understand what can we do to make the tools even better. Our next steps for the PedsPac project are obviously ongoing coaching with the implementation process, developing and finalizing new PedsPacs, and those are going to be determined by what the needs are, how useful emergency departments find them to date. We've had really excellent feedback on the usefulness of the PedsPacs and how important a resource that they are. So we're certainly feeling validated and feel that we should be continuing with this work. I mentioned the app. The app that we're working on is a general app for all the resources on the TREKK website, but we're going to have a particular section of the app related to PedsPacs. We know that the hard copy of everything is always going to be important. The visuals are really important in an emergency department given the chaos and complexity that I talked about before. So we will always need those hard copies, the posters, the binders, but in some situations it will be really helpful to have the app as well. And so we are working on that and hope to have a user interface ready towards the end of this year. And then finally we'll have evaluation of the usefulness and the impact and the influence of the PedsPacs. And we're actually doing research studies and collaborating with investigators in the United States who've gone about a similar thing in a very different way, and we've actually come together and we're looking at evaluating the PedsPacs in a number of emergency departments in the United States to look at the impact there. And I'm just going to end with this slide and make sure we have time for a discussion. In terms of PedsPac implementation, I've listed 4 key groups that are really going to be important in ongoing implementation and utility related to the PedsPacs. Obviously, emergency health professionals, in particular nurses, physicians, respiratory therapists, pharmacists, really need to become familiar with the PedsPacs, that they exist as a group, that there are different types of PedsPac topics, and how they're organized so that when they're in that moment they can go to it quickly and don't need a lot of lead time to understand how to use the tools. Emergency and or hospital administrators, I think, have a really important role in helping set up the system to support the health professionals to do what they need to do. In some conditions, we know that the types of tools that are required or equipment that's required may not be available in that emergency department, so it's helping to get that type of equipment available and accessible in the resuscitation room. Sometimes it's dedicating people to actually work on implementation in the emergency department. It's dedicating space in the resuscitation room for the PedsPacs and other related tools, etc. So we're really looking for support and assistance from the administrator group. Pediatricians. So pediatricians are obviously integral to all of this, and we're really trying to reach out to the pediatric group. So I'm very delighted to see that there are a number of pediatricians on this webinar today. It's really important that pediatricians are aware of PedsPacs, especially because we want to make sure that the management that we're asking the emergency department teams to be using is not going to be different from what the pediatricians are choosing to do. So most of the severe conditions will require the involvement of a consultant pediatrician in that community emergency department. It's really important for the sake of the patient and the family that we're all on the same page with the recommended treatment. And hopefully, if we're all working from the best available evidence, that we will be on the same page. But I hope that the pediatricians will take the time to review the PedsPacs and understand what's involved with them. And if groups feel that the recommended management should be different, then that's important feedback for us. And then finally, the pediatric referral hospitals, as I've mentioned, are really going to be integral with helping with the initial implementation activities and teaching around the PedsPacs and with ongoing coaching and support to ensure optimal use of the PedsPacs. So with that, I will turn the controls back over to Doug and Ann at CAFC and be ready to discuss any questions or other issues that may have emerged during my presentation. Thank you.
All right, thank you, Dr. Jabbour. Great presentation and a great refresher of some of the things we already knew about TREKK and some of the great resources there, and a great presentation of some of these new PedsPac items that you just discussed. One of the things you did ask was you had the list of PedsPac, the current PedsPacs, and you asked if people had any suggestions for other ones. We did have a few suggestions come in. So other suggestions they talked about were, someone mentioned massive hemorrhage. So she said related to multi-system trauma, but perhaps a separate one for massive hemorrhage. Hypercalcemia hypocalcemia management, and hypothermia interventions were all mentioned. So.
Wow. Okay, those are great suggestions. Can you tell me hypothermia? Okay.
One of the other things that sort of came to mind as I was looking at the list as well, and I'm not sure this would be relevant for a PEDS PAC or not, but the one thing that sort of jumped out to me, the question that we often get asked here related to children presenting in emergency departments, are those presenting because of mental illness? I was just sort of curious as to whether you saw a role for TREKK and perhaps a PEDS PAC related to children presenting with mental illness. I mean, it's not as simple as some of the other ones where it's about pulling together sort of known evidence and best practices. It's a little more complex with children, with mental illness. But I'm just wondering if you had any thoughts around, or if there's any potential or any conversations at TREKK around a package for that.
That's an excellent question. Definitely something we've thought about, and mental health issues, especially related to the emergency department, is another area of interest and research for me in particular. We're all very aware of the increasing presentations of mental illness amongst children and youth. And in the emergency department, our role is really about assessing risk. It's not about diagnosing. It's not about treating in particular. Emergency physicians are not good at mental health management. I can say that as an emergency physician, that's not our area. But what we are good at is assessing risk. And so a lot of the work that I've been looking at is around system navigation based on the risk assessment that we do. And so we are looking at future work through TREKK related to mental illness. It may or may not be relevant for a PEDS PAC. It may require a different type of tool or set of tools, but it's definitely something that is on our radar because we're very aware. Anyone who works in an emergency department knows it's a big, big issue.
For that, and Laurel mentioned that the Hospital for Sick Children in Toronto has a mental health guidelines for management of patients during crisis to ensure safety of patients and risk reduction, sort of that approach that you mentioned for emergency physicians and this not being experts in that area. There are some people looking at that as well, and perhaps an opportunity to work nationally to sort of standardize that kind of practice.
Yeah.
So another question that just came in was from Yasmin. She's asking if you could expand on the evaluation of PEDS PAC and the evaluation at U.S. emergency departments, but not in Canada.
Okay. The reason that we're doing a specific research study, we're definitely looking at evaluating the impact of the PEDS PACs in Canada in the emergency departments that are actually using the PEDS PACs. We are definitely planning to do that. The challenge with that is that we don't have the appropriate databases set up in all centers to actually be able to track it. So it's going to have to be a very resource-intensive process to actually track that activity. But we definitely need to do that, and we'll be doing that. The reason that we are studying this in a research context with collaborators in the U.S. Is that they've actually approached us, and they're quite interested in looking at this. So they came about it in a different way. In the United States, people may or may not be aware of this. I wasn't aware of it. Emergency Medical Services for Children, EMSC, is a national program that exists in the United States. It's federally legislated, so every state is required to have pediatric tools and programs to deliver pediatric emergency care in any emergency department. So that is something that's legislated, and every state has to have a plan of how they're going to basically create pediatric readiness in every emergency department. So some of my colleagues have actually done this. They've gone and delivered SIM education at all these places, and then went around and evaluated and found the readiness was still not optimal. And then they heard that we were creating these PEDS PACs, and they realized, oh, that's what we need. We need something that will actually help really prepare them in the moment, regardless of what their background training was. So they're interested to actually evaluate the impact of the PEDS PAC on top of everything else that they've got going on. So that's really our rationale for doing that. If anyone has any other suggestions for evaluation, I would really love to hear about it.
All right. Yeah. So if anyone does have any suggestions around that, please don't hesitate to contact Dr. Jabbour directly or contact us. We can certainly put you in touch with her. So yeah, for the rest of the audience, if you do have any questions, we did have a question come in about clarification around some information on the pocket, but Lois has said that to disregard, she's managed to resolve it on her own. Yes, if there are any other questions, we do have a couple more minutes left. If there are any other questions, we'll give everyone a chance to type one in just over the next few seconds. But while we're waiting for any final questions to come in, maybe you could, Dr. Jabbour, you could let us know sort of what people could be taking away from this or preparing for in the future, as far as what opportunities they could expect from TREKK, either related to the PedsPacs or other interesting things that TREKK might be working on that people could be expecting in the near future.
Yeah, that's a great question. For now, what I'm hoping that people will be thinking about is thinking in their own hospital context. Whether you're an administrator, whether you're a pediatrician, an emerge nurse, think about your emergency department and how a PedsPac might work in your setting. What's required to make it happen? Is there a need? Do you feel like there is a need to have a PedsPac? How do you actually make that happen? Who would you contact? What can we do to help you to have that in place? A lot of the interest that we've had has come from sites where they've had a very bad or unfortunate outcome with the child, and that obviously spurs interest, but hopefully people will be motivated to do something before something like that happens. And we know for every mortality that exists, there's probably a lot of morbidity where things could have run more optimally. So hopefully people will go away and be thinking about it and talking within their hospital and emerge context about how to make this happen. At TREKK Central, we're actually we're continuing to develop more tools, populating our website. We really want to have the TREKK website as the go-to place. So you're in an emergency department, you've got a pediatric patient in front of you, you don't remember, you want to optimize what you're doing, whether it's a critically ill child or really any child, you want to go on and find the resource that will be helpful in managing that child or managing the family, which always goes hand in hand with the child. Having a number of really good, meaningful resources aimed at patients and families that will help them to really take ownership in their health issues. So we're really working on both of those fronts. And then, as I mentioned, we're continuing to go on and have that outreach presence with community hospitals to really help deliver this message and ensure optimal care is being delivered.
All right, we did have one last question come in that maybe we can answer before we sign off. But the basic question is how to get started. How do we collaborate? And I think we've got an interesting mix in the audience from those from within sort of the larger children's hospitals and in the larger centers, the academic children's hospitals that have information or are well connected with TREKK or are part of PERC, et cetera, who maybe are not exactly sure how to engage, those community hospitals that may or may not be involved. It may be clinicians within the emergency departments that aren't aware of the connections with TREKK or the national network as well. It may be individual clinicians that are just not aware of that. Or on the flip side, we also have lots in the audience from those community hospitals who, again, may not be aware that they are connected with a children's hospital through this network. So where's the best place they can go to find out if they're already connected to the TREKK network or how to become connected to the TREKK network?
Okay, that's a great question. And really, although we started with our TREKK network with a limited number of community sites, that was really for logistical, feasible purposes because we had limited finances to actually do this. We still have limited finances, of course, but we really want to be more inclusive. And the resources that we have created are really available to anyone, really even outside of Canada. We're primarily targeting Canadians, but they can be used outside of Canada as well. probably the best place to go as a first pass is TREKK.ca, TREKK.ca. That's our website. All the information that you need will be there, including contact information. Our network broker, our network manager rather, is Lisa Nisley, and she's probably the best person to connect you. Depending on what your needs and interests are, she can contact any of us. We have a number of as I mentioned, including in addition to our TREKK executive, we have a number of leads at each one of the pediatric hospitals. We have a number of content experts for the various conditions, and so it really is a very large and diverse team of people that can be brought in depending on what it is that you're interested in. And most likely what Lisa would direct you toward is your pediatric referral hospital and the representative at that hospital to help begin the discussion of how to do this implementation for your site in particular.
All right, and I think with that, we will wrap up. Thanks again, Dr. Jabbour. Great resource. TREKK has always been a great sort of a program that's really done a lot of really good work on pulling together those bottom line recommendations and those simple sort of evidence summaries and that sort of thing. So some great resources there in addition to the PedsPacs. So thanks very much to TREKK for all the work and to your leadership in that group.
That's great. Thank you very much.
All right. We do our webinars every Wednesday at 11 a.m. Eastern Time, so it's great when you can watch live, as you do get the opportunity to ask your questions. But if you can't watch live, we do record these sessions and make them available after the fact on the CAFC Knowledge Exchange Network at ken.cafc.org. Next week, on June 7th, we're going to hear from Dr. Jonathan Lai from York University and Esther Ree from Autism Speaks Canada about people with autism spectrum disorder and their families. What services do they truly need? And in this webinar, we will discuss the landscape of perceived service need in autism in Canada and address gaps in navigation support for clinicians to community resources. Dr. Lai will present some of the research that he's been compiling over the last couple of years, and Esther Ree will talk about the impact on families of having either access or lack of access to those services. And then following that, on June 14th, we will welcome back Dr. Stan Kuchar from Dalhousie University and the IWK Health Centre in Halifax to talk about pathway through mental health care, the complete and comprehensive school approach. And the pathway through care model presents an evidence-based method for identifying youth who need mental health services while not creating demand for youth who do not need it, by helping increase the mental health literacy and help-seeking ability of teenagers and their teachers, as well as linking healthcare systems to schools. So that should be a topic that will be of great interest to many in the audience. So as always, some great stuff coming up in the next couple of weeks. Thanks again for joining us today, and we hope to see everyone back here next week. Bye, everyone.